Welcome to new treatment updates for advanced GIST. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild. I'm the VP of Program Services, and I am your moderator for today. We would like to thank Decipher Pharmaceuticals and Genentech for their unrestricted educational grant for today's webinar. And now I would like to introduce our presenter for today. Dr. Bill Tapp is the Chief of the Sarcoma Medical Oncology Service at Memorial Sloan Kettering Cancer Center in New York. Dr. Tapp has extensive experience in translational medicine and is currently in charge of the clinical basic science and translational aspects of the Sarcoma Medical Oncology Program at MSK. He's a dear friend of the LifeRef group, and it is a pleasure to have him present today. Dr. Tapp, please take it away.
So Sarah, thank you so much for having me and the LifeRef group for having me today. I'm just going to work on getting my slides set up here. It's always a pleasure to speak to you. And I thought what I would do is kind of give a little bit of an overview regarding how we're approaching GIST today in drug development as well as patient care. Some of my slides may seem a little technical, but I'll try to talk through them to see if they can really help explain again how we approach GIST and how we may look to develop some of the newer treatments. I'm just going to make sure my slideshow is set up here. Just give me 1 second. Good. Okay. So I'd also like to start with my disclosure slides. These are companies that we work with routinely and have had interest in developing therapies for GIST. And most of the time, when we work with these companies, we do it in an advisory capacity to think about their compounds and also talk about how they may be applicable for GIST patients. And some of the things that we're going to talk about too a little bit today is where we are in the crux of some of our clinical trial designs, and not only what that may mean to you as an individual patient, but good or bad, how that can help us bring some of these treatments to the market. So I'd like to start with some of the background of what GIST is and how that shapes our thinking about how to apply therapies to it. For a long time, GIST was thought to be a leiomyosarcoma of the GI tract, which was a tumor of smooth muscle. But it was really some interesting observations in the 1990s that really helped us identify, or helped the GIST community identify, what may be the actual cell of origin of GIST. And the cell of origin is thought to be a cell that's known as the interstitial cells of Cajal. Cajal was actually a Spanish neuropathologist who identified these cells, which sit in between several of the muscle layers of our GI tract. And these are really neurological cells that help our GI tract with the motility of food as food is really beginning to be digested, something that we call peristalsis, which is how the bowels can actually dilate and contract to move food along through the digestive process. And why was this important? Because when we really had a cell of origin, it allowed for a lot of smart researchers to try to figure out what is going on in GIST. And what we know with interstitial cells of Cajal is that when the interstitial cells of Cajal develop from stem cells, which are kind of the pluripotent cells that can develop in the body into a lot of different types of cells, they do rely a little bit on KIT signaling, but it really plays a minor role. But as these cells develop into what we call a progenitor cell, where they're going to want to develop into mature interstitial cells of Cajal, they really rely on KIT signaling. And that was a really important discovery because it began to introduce KIT, this receptor we always talk about in GIST, as having some potential in the formation and the development and propagation of gastrointestinal stromal tumors. So we talk a lot about these KIT receptors, and this is really a simple cartoon of what the KIT receptor is, but we always describe it to our patients as being like the old rabbit ears antennas on TVs, where these are transmembrane receptors. And what they actually do is they can receive signals from the body when the normal cell would need to grow. So when they receive one of these signals, the receptor is actually turned on, and then a bunch of events happen within the cell, usually ending up in the nucleus of the cell, telling the cell it's okay to grow and divide, right? And that's the importance of these receptors. Again, these are very linear and simplistic descriptions of actually what happens. But I think for principles, as we talk about this KIT receptor, this may give us a good point of reference of where to start. And again, these receptors are transmembrane receptors, meaning they have something on the surface of the cell that can actually receive a signal from the cell. And then they have a component within the cell. And these are different components that can then allow for the activation of these cascades. And generally what happens is it causes a protein to activate another protein to activate another protein, and then getting inside that nucleus and having the cell begin to grow and divide. And it was important when there was some thought that KIT may be related to GIST. And always in a simplistic form, the question was, is this KIT receptor overactive or underactive when it comes to a potential disease? But what was interesting is there is a hereditary condition in where people are born without the function of these KIT receptors, and they have very characteristic clinical findings. They tend to have hypopigmentation within the skin, and sometimes with even the forelocks of the hair. And the reason is this KIT receptor is also important for melanogenesis. And this is a disease that is called piebaldism. And it's named after the magpie and the bald eagle, which also have these, kind of whiteness within their skin. Interestingly, this is not how people with GIST look like. So there was some question that maybe it wasn't a down regulation of this receptor, but maybe an overactivity of this receptor. And there were several groups in the later 1990s. One of the more prominent ones was a group from the University of Kyoto in Japan that actually showed that what happens in GIST is that these KIT mutations are always turned on. So there's generally a mutation within the receptor that keeps the receptor in the on position, even when it's not receiving signals from the cell to grow, right? So that's allowing these cells to continue to grow even when the body, doesn't necessarily want them to do that. And this was a really important and sentinel finding because almost overnight, it put a very specific mutation into something that was, not only driving the pathogenesis of GIST tumors, but also the propagation, what was really keeping it going. It also gave us a test, which we look at, which is CD117, which is really staining for this KIT receptor in tumors. So again, almost overnight, a lot of people who were misdiagnosed in the late 1990s as having a leiomyosarcoma could all of a sudden be diagnosed as having GIST. And more importantly, at the time, there were drugs that actually targeted KIT. And these drugs were drugs like imatinib, which we know a lot of today, that were being developed in a chronic form of leukemia, CML. And then thankful to some real strong patient advocacy, as well as some advocacy of many clinicians at that time, there was the application of KIT in people with advanced GIST. And again, very quickly, we saw tremendous activity. And these are just some of the studies that led to the eventual approval of imatinib in patients with advanced GIST. So I think this is one of the hallmarks of drug development and application in cancer care. And in the early 1990s and 2000s, this was a really good sign that if you had a disease with a very specific abnormality, if you found the right drug for that abnormality, you can really help patients. And this has revolutionized our care for patients with GIST. But it's not that straightforward, because we know that there's a subset of people with GIST that are resistant to the disease, to the drug, excuse me. But we also know that people with really advanced disease, after they use imatinib, generally on average for about 18 to 20 months, you can begin to see resistance develop. And the question really becomes is, why does this resistance develop? And we talk about resistant mutations, and there was some really nice work done from some of the data of the early clinical trials, which shows that tumors that begin to develop resistance to imatinib actually have mutations in other areas within that KIT receptor. And there's two specific areas that we tend to talk about. One is in what we call the ATP binding pocket of that KIT receptor. And down here is a clinical structure of what KIT looks like. These are just all of the different loops and helixes that a true receptor has. And what it shows is that there can be mutations in kind of the work component of this receptor. And for these receptors to turn on other proteins, they tend to have to phosphorylate them. They have to move a phosphate group onto these other proteins. And they do that by taking these phosphate groups from a very powerful molecule in our body known as ATP. And one of the areas that we begin to see resistance develop is this ATP binding pocket in this GIST receptor. So we see these mutations, what are commonly referred to as mutations in exon 13 and 14 in GIST. And there are also these other groups of mutations in exon 17, 18, which we often refer to as the A loop or the autoinhibitory loop, or also the phosphotransferase region, another a specific component of these receptors that are critical in moving these phosphate groups around. And these are predominantly the reasons we begin to see resistance. A more simplistic term is it's almost like a lock and key, that these mutations kind of change the lock around in a way that drugs like imatinib can no longer fit into this crystal structure, how it's folded, and really help shut down these receptors that are always turned on. But it's not that simple. Although the majority of the time of these secondary mutations are what cause resistance, there's a whole bunch of other reasons we're also finding that can also contribute to these drugs becoming resistant in GIST. And these becomes important as we talk about, and we're developing more complex drugs against the various resistant mutations. We also have to begin to think about the other ways that cancer cells really can avoid being sensitive to these medications. So it's a complex system. And what we have been able to do, and there's been, again, some really nice work from some of our colleagues, not only in cell lines and just cell lines in a cancer dish, but also from human samples taken from clinical trials, is that they can begin to map out all of the areas within these receptors, the exon 13, 14, 17, 18, where these mutations begin to develop, and what are the very specific mutations. And then when they figure out the very specific mutations, they can see how it affects the functioning of these receptors. And importantly, they can then test out a bunch of different drugs against these types of mutations to see which ones work the best and which ones don't work. And as clinicians, this has given us a lot of powerful information to understand that if we think we know what are the predominant mutations that are conferring resistance to a drug like imatinib, we may be able to tailor appropriate therapies for our patients. So very fundamental information that was being developed. And interestingly, this was mirroring similar work being done in diseases like chronic myelogenous leukemia, which also developed resistance over time to drugs like imatinib. And why was this important? Because it really did show that some of the drugs we had in our repertoire at the time, like drugs like sunitinib, which we use as a second-line treatment, can really treat certain groups of mutations better than others. And so this was an all-comer clinical trial that led to the approval of sunitinib in the second-line setting. And what it showed is that when you really scrutinize some of these mutations, drugs like sunitinib actually seemed to work better when there were mutations in the ATP binding pocket, that exon 13, 14, as compared to when there were mutations within the A loop, exon 17, 18. So again, showing these differential response patterns. And these were the data that begin to set up in our mind that if we can understand what mutations we're developing, we may be able to appropriately offer patients drugs. Again, Sutent or sunitinib is actually approved for all comers in the second line setting. But we believe that if we can appropriately apply these drugs, we may allow for longer term, better and deeper responses to our patients. But it's complicated because what we know is that when this resistance develops, it's just not one resistant mutation. In that, in people who have a lot of tumors in their body, we can see multiple mutations developing. And the problem is we sometimes apply a drug and it may be able to treat a specific resistant strain and may help within a tumor or a few tumors, but there may be other tumors in the body. And those tumors could continue to grow because we're not targeting them correctly. And this is an important concept because as clinicians, it always put us in a reactive state. We needed to try to get ahead of the disease as opposed to just reacting to certain tumors. And this kind of equated the analogy of the game of whack-a-mole, that you were trying to just knock down anything you can, but you weren't really solving the problem. And our community has really moved away from this concept to saying, you know, we don't want to be reactive, we want to be proactive. So there's a lot of effort being placed into really understanding how these mutations develop. You know, what is the spectrum of the mutations that we see, and can we actually develop drugs that can target many of these? Because once we can begin to target many of these, then we can also bring in potential treatments that can target some of the rarer, but again, sometimes very powerful additions that these tumors begin to get resistant to our therapies. And there is a question in the field and how these mutations begin to develop. I'm a believer that a lot of these mutations exist when there's a lot of disease within the body. Drugs like imatinib can suppress the most dominant mutations, which are often mutations in exon 11, this primary mutation we talk about. But as we begin to suppress a lot of these, the more powerful mutations, what ends up happening is these secondary mutations then begin to emerge. In other words, the therapy begins to select for them. And this calls into question if we can have medications that work on a wider selection of mutations, could that really help prevent the development of the resistance? There is some data, and some people believe that these mutations develop spontaneously over time, right? And that's another possibility. So these are active areas of research to really try to understand how these tumors are reacting and adapting to the medications that we actually use for our patients. And again, why is this important? Because this has allowed companies to begin to map out some of the drugs and chemical matters that they have in their libraries to see how broad of an inhibitor it can be against various mutations in GIST. And this is just one example that I pulled because it's very nicely done in our medical literature, where at the time a company had a compound that was a potent KIT and PDGFR alpha inhibitor. PDGFR is another receptor, much like KIT, that is also abnormal in a subset of people with gastrointestinal stromal tumors. And what these companies can do is actually look at the chemical structures and then see how these chemical structures can actually fit into the crystal structure of that KIT receptor. And then they can map out all of the different mutations and put them into this crystal structure and see how it changes that structure of the receptor, and then say, do we think our compound can still work? And this becomes powerful because it begins to let, again, the companies know if they have a drug that will specifically inhibit various types of mutations. Now, the other thing that's important with these drugs is that they tend not to just hit the KIT receptor. And these are what we call kinomes, which diagrams of the different compounds that we know about that can actually show us what other types of receptors they hit. because sometimes having a more promiscuous or dirty drug can be very helpful because it can target some of the other ways that these cancer cells are trying to grow. Other times it can also bring in more toxicity or side effects, right? So there's a lot of debate as to what is the right mix of strongly targeting the KIT receptor as well as some of these other receptors based on efficacy, potency, but also toxicity. And then when companies have these compounds, what they can actually do in the lab is look at the various mutations. They can look at the primary mutations and they can compare their drug to other drugs that we use. They can look at resistant mutations, say in the ATP binding pocket. And they can look at resistant mutations, say, that develop from exon 17, 18, or the A loop, and look very specifically at these mutations and develop drugs that have broader spectrum of activity. Not only can they look at these mutations within cell lines, but they can actually look at tumors that they engraft in mice and feed the mice the compound and see how much stronger their compound is against some of our conventional therapies, again, in tumors that have these different mutations. And this becomes a very powerful asset because then what they can do is develop a whole chart spectrum of what they perceive before people get the drug, how extensive this drug can work. And this is important for us because it can then give us thoughts about how to appropriately develop the drug, and most importantly, how do we apply it for our patients. And one of the drugs which also eloquently did this was a drug we now know, which is Repretinib, which is a drug that was recently FDA approved for patients in the fourth line setting. So after drugs like imatinib, sunitinib, and regorafenib. We were very excited about this drug for a long period of time, again, because of the broad spectrum of activity that some of this preclinical work showed. And what Repretinib is a drug that we call a switch pocket kinase inhibitor that can actually sit in this crystal structure and prevent this kinase from switching to an on and off period. So prevent these receptors from turning on and off and kind of keeping them in that off position. And because of this activity and because of some very nice work done in early clinical trials, Repretinib went into a very large randomized phase 3 study to try to gain approval of the drug. Now, importantly, this again was in people who had been treated with imatinib, sunitinib, and regorafenib. And the way the trial was designed was to compare Repretinib to a placebo, so the drug to nothing. And then people were followed, and if they were given the placebo and their tumor began to grow, they could actually get access to the drug, right? So there's becoming a lot of controversy now as to whether or not placebo-controlled studies are the right way to develop drugs in GIST. And this is an example. These are what we call the Kaplan-Meier curves, and it shows how well people do, how well people do over time when getting a treatment. And what you can see by this red line is that people with advanced tumors, when they don't get any treatment, their tumors rapidly grow. Whereas when they stayed on the drug, they actually begin to control the tumors, and that's important. And these are how long people live. And what you can see is that people on the trial who got placebo, even though they were able to get the drug after their tumor started to grow, they didn't do as well in the long term, right? So this questions our design of clinical trials and whether or not placebo is the right way to move forward in clinical trial designs. On one caveat, it's easy for a drug to beat no treatment, right? So these are ways to get drugs approved, but is that the right thing for the patient? And do we need to think about other strategies of comparator studies, which we're going to talk about a little bit? But what this showed is that people with advanced tumors who actually progressed on several lines of treatment actually had stability on an average of about 6 months with Repretinib. So it really did begin to show some activity. We'll hold that for a little bit because right about the same time, there was another drug the community was very excited about called Avapritinib, which also went through this extensive preclinical work and was being developed in GIST. Importantly, for this drug targeted a very rare mutation in GIST, in that PDGFR receptor called a D842V mutation. And this was a mutation that was very insensitive to Gleevec, and we didn't have great therapies for it. So on the phase 1 clinical trial, a lot of people with this mutation actually received the drug, and the responses were remarkable. You can see that these are all the people who actually were having dramatic responses to this therapy. And almost off of this early data set, this drug gained approval as a first-in-class for this mutation. So it's a very important drug, not only in our understanding of how to design compounds for some of these rarer mutations, but also how to develop it, and now offering people a very good treatment. But the phase 1 clinical trials also looked at people who had more advanced GIST with conventional mutations. And so it was a complicated trial design. But what it did show is that there was also a reasonable response in some of the patients with more advanced tumors who had progressed on other therapies. And so because of this, another large clinical trial was developed. And I just wanted to fast forward to this. So this is a busy design, but unlike the Repretinib study, the thought was to compare Avapritinib to a drug that's already active to see if the Avapritinib drug could actually help more patients, potentially because it was better tolerated, or potentially because it targeted a broader spectrum of those resistant mutations. Regorafenib, which is commonly used in the third line setting, we know is a good drug against the A-loop mutations, the exon 17, 18 mutations. So the hope was that Avapritinib could not only help patients with those mutations, but potentially a broader spectrum of mutations. But importantly, this was one of the first clinical trials in GIST that didn't go into the study trying to compare their drug to a placebo, but rather using what we call an active comparator, a drug that we know has activity in GIST. So this also calls into line what can be the issues about a clinical trial like this that affect the outcome as opposed to just the activity of both agents. Now, this was an important trial because what it showed is that there was no difference to Avapritinib and Regorafenib when studied in this setting. In fact, Regorafenib looked a little better. The study also uncovered the fact that Regorafenib is although difficult drug, it's something that people know how to use clinically and can really make sure that it remains consistent for their patients. Whereas it also unmasks some atypical side effects with Avakit or Avapritinib, specifically in that it could cause some neurocognitive issues with patients, right? So it begins to see the full spectrum of usage patterns and side effects when we do these larger clinical trials. But importantly, it really showed no difference. And it was disappointing because in the preclinical data, we really believe that Avakit may have a broader application. So our community, especially in one of the first clinical trials that was comparing a new drug to an active comparator, is trying to understand, are there any facets regarding the drug itself, the toxicity of the drug, or the type of people that are enrolled in a clinical trial, understanding the heterogeneity of their diseases to begin to understand why we saw the results we did. It may very well be that Avapritinib is not a better drug than Regorafenib, but we need to tease out and understand the heterogeneity and the diseases that were treated to fully understand who best should receive these drugs and why. It also calls into a lot of questions about clinical trial design, how we interpret early data, and then how we design larger regulatory, what we call pivotal studies, in which we're actually trying to get FDA approval. Because oftentimes when we're working on smaller studies, we're dealing with just a few sites. These are always in the hands of experts. We may select patients that are right for the study. But when we begin to do these larger international studies, we bring in a lot of variation, not only in clinical practice and expertise, but also in the types of patients on larger studies as compared to the types of disease that we see in the earlier studies. So these are very important clinical trials because it not only begins to inform how we interpret early data from the lab and early clinical studies, but how we actually design studies and then almost retrospectively go back to the outcomes and understand the data so we can really truly appropriately apply these medications for our patients. Now, why is this important? Because Repretinib, which has already been approved, is currently in a clinical trial where it's being compared to sunitinib in people in the second line setting. So after their disease has become resistant to imatinib. Now, there's a lot of interest in this study, and it's a really important trial design because, as I mentioned earlier, one of the goals is if you have a drug that can not only target the primary mutations, but also many of these mutations that cause resistance. If you can apply one of these drugs earlier on, are you able to prevent or delay this resistance from developing, right? So this can be a very clinically important study to understand not only how Repretinib acts early on, but can we actually help people for longer periods of time? And this is critical. But it does call into the complexity of these comparator clinical trials, right? Because there are a lot of caveats and features, again, from the heterogeneity of GIST tumors that actually see these treatments to concepts of trial design, practice patterns, right, that may happen in a larger international study. But a very important study that we're waiting for the results to come out. But again, conceptually, what this does is it calls into question the ability to bring some of the newer therapies, more comprehensive, potentially targeting a wider strain of mutations earlier on. So not only do we target the primary mutations of these tumors, but we can actually prevent some of these resistant mutations from being clinically significant over time. An example of this was some nice work done where they were looking at two drugs. One of the drugs was called PLX9486, combining it with a drug called sunitinib. And why was this concept thought of? Well, we know that sunitinib can really target some of these resistant mutations, especially in the ATP binding pocket, whereas drugs like 9486 can really target some of the resistance that develops in mutations near the A loop, right? So the thought is by combining these two drugs, if we don't have worse toxicity, could we actually allow for better killing of these tumor cells, regardless of the type of resistant mutations that they have? And so this was an exciting concept. It looked at different doses and schedules of these inhibitors, but it was an early study. A complex study, but what it did show is that people who actually had fairly aggressive disease, we could see this combination offer some nice benefit for them. And when we look at how patients did, people were actually on drug for significant periods of time, and people could have strong and deep responses that lasted a long time. Now, again, this is going to be a smaller study, more of a proof of principle study, but it gains a lot of excitement to suggest that possibly using a combination that has broader activity against a lot of these resistant mutations in an earlier setting could be a very powerful tactic for patients. And what this showed is that the average that people were on this drug was 11 months, which is a good amount of time. But again, holding in the caveats of saying that this is going to be a smaller, more selected population in the hands of just experts as compared to a larger study where we're bringing in hundreds of patients to truly understand the signal and the safety of a compound. But as we begin to have development strategies like this, it's also very important that as the next level of clinical trials are developed, especially those regulatory clinical trials, that we design studies that can actually mimic these results, right? We don't want the heterogeneity of a disease or practice patterns to begin to dilute out the results that we see. So we truly have to understand the characteristics of the people who responded and why, and see if we can best mimic that and reproduce that in some of the larger clinical studies. And one of the ways to do that is to begin to scrutinize everyone that was on trial to best understand their disease. And now there's a lot of way to look at the cells of circulating tumor DNA in the blood to see the different mutations that are there, help us understand what this polyclonal resistant looks like and how these drugs are acting. And not only doing it in trials like this, but going back and looking at these types of studies in the original or the most recent studies with Repretinib and Avapritinib are going to be really important in gathering enough data so that we can begin to take a snapshot of a patient at any time, understand what is the complexity of their disease, what are the specific mutations that are driving the disease, and then how we can appropriately offer treatments that are best targeting their disease. And although we're not there yet, we're getting a lot closer. And these trials that so many people have invested in are going to be critical in helping us understand that. But it also, again, begins to question how we can move stronger treatments earlier on in people's care. And not only that, but are there ways to potentially target other aspects of this disease than just these resistant foci? And there's really interesting emerging data regarding MEK inhibition in combination with tyrosine kinases like imatinib or potentially Repretinib. And what is that? And that this all stems from really interesting work from Ping Chi, who I'm fortunate to work with at Memorial Sloan Kettering, who made some really interesting observations. The observations were that KIT is a gene that our body uses for a lot of different functions. But when it's mutated, we really only see cancers develop in specific diseases such as GIST. So the thought was, what is it different about GIST that can help us understand this disease and potentially identify other genes and proteins that may be important in the development of the disease? And I think Ping had some really astute observations. And what she found is that although these interstitial cells of Cajal are involved with several layers of the muscles within our GI tract, it's only from specific areas that GIST can develop. And what Ping found out is that there was another gene called ETV1 that was always associated with the interstitial cells of Cajal that developed into GIST tumors. So she posited that ETV1 is very important in addition to KIT in developing these tumors. And this is just an example with some of her work that she did in mice, that it was only the tumors that actually had ETV1 and then a typical KIT mutation that actually developed GIST tumors. And this was really important because it had allowed Dr. Chi to go into the lab and really figure out how KIT interfaces with ETV1. Now, ETV1 is a gene that we call a transcription factor. So it sits in the nucleus. And when it's active, it tells the nucleus to actually grow and duplicate. And she showed very eloquently that the KIT receptor can actually signal in a pathway called a MAP kinase pathway that can activate ETV1 and allow cells to grow. But importantly, ETV1 then can further stabilize KIT. So there was a loop where these two genes were connected. And what was important is finding how the KIT receptor actually interacted with ETV1, because in medicine, it's very hard to target something in the nucleus, but knowing this pathway allowed Dr. Chi to identify a drug called a MEK inhibitor that can actually help shut down this pathway. And when she showed that she can shut down KIT signaling with a KIT inhibitor like imatinib, and then also inhibit MEK signaling, you could get greater killing within the GIST tumor. And that was really the goal. And this led to a really novel clinical trial that Dr. Chi ran where she was introducing the combination of a KIT inhibitor with a MEK inhibitor in newly diagnosed patients. And this was important, again, because not only did she want to see this effect happen earlier on before all of this resistance began to develop, but it needed to be done at a time when the drug like imatinib could really have strong activity, because without the activity of imatinib or anything against KIT, the combination probably wouldn't have worked. But it's a very difficult trial because most people with GIST are now, seeing imatinib as soon as they have a diagnosis. But over the last few years, about 40 patients with newly diagnosed disease were actually enrolled onto the study. And the results were recently presented at our big cancer meeting last year, and they were really intriguing in that we were beginning to see these types of outcomes that were exceedingly strong, where about 60 to 70% of the patients who received the combinations had dramatic responses. And these responses were durable, but also deep when we looked at them from a tissue level or when we looked at them from an imaging level. And people who are actually on drug seem to be on drug for a significant amount of time, potentially much longer than they would be on with imatinib alone. So again, a smaller data set, but very intriguing that potentially this combination could be allowing drugs like imatinib to work for a longer period of time and have a much stronger killing effect against the tumors that are in an individual's body. And one of the ways that Dr. Chi noticed this is in the handful of patients that actually started this and had the tumors resected. And when they were looked at under the microscope, the majority of the tumors were dead. And this is something we can often see with imatinib, but not to the extent that was really seen here, suggesting that there is a lot of activity and synergy between the compounds. And again, people had a median time of responding to the drug of about 30 months, as opposed to what is historically thought of about the 18 months. Again, we have to be very careful because we're comparing smaller data sets at a single institution to larger historical data sets, right? But maybe thoughts that there is nice activity of the combination. And could this combination of a MEK inhibitor with a strong tyrosine kinase inhibitor, potentially one with a broader spectrum, actually begin to strengthen our treatment for patients with GIST from the beginning of their diagnosis, potentially before all of these other mechanisms of resistance begin to develop. And what is nice about the work is that there was a lot of data understanding why the treatment worked, and when it stopped working, why did that happen? And this, adding to our collective of data, will be very important to figure out how to apply drugs. And there was also some anecdotal reporting that it could also help in succinate dehydrogenase GIST as well. So a few patients with what was previously known as wild type GIST, now succinate dehydrogenase GIST, were actually put on the study. And so we're really interested for these data to emerge to see if it may be an adjunct to help people where we don't really have great treatments for, much like Avapritinib did in the D842 mutated tumors. But these are not the only treatments. I want to end with a few slides. This is nice work of a drug called cabozantinib, which also targets a gene known as MET. And there was a lot of preclinical work and clinical work showing this may be a good strategy. Again, calling into the selectivity of a compound versus its side effects. And there's tremendous work being done on understanding how the immune system is involved in killing GIST, not only when people get imatinib, but when drugs like imatinib work, how does the immune system contribute to that? And are there ways to augment this? So there's a lot of hope in GIST, and not only developing new drugs that handle a broader spectrum of the gists that we have in our body, the heterogeneity of the disease in a person's body, but then what are the different ways in which we can develop newer strategies also to augment these treatments. And importantly, the GIST medical community is now sitting on a large amount of data in which we can begin to understand not only how to appropriately apply these drugs, but also study them so that we really can try to move the drugs and concepts forward that make the most sense for our patients. And I wanted to end there with about 15, 20 minutes left so we could have a discussion and answer any of your questions. And I hope this was helpful in a little understanding of how we approach DRIS, but how we also interface with some of the drug communities to develop new therapies for people.
Thank you, Dr. Tapp. I felt like you gave us this like appetizers of like different options. And it's so nice to see that there's a range of options for patients with advanced GIST, as well as just the important translational work that you're doing with your GIST team, and just providing hope for patients that there's more on the horizon. So thank you for that. Just to get started, these are actually 3 questions that came together. Approximately what percentage of exon 11 patients develop resistance to imatinib, the average time to becoming resistant, and does surgery to remove GIST lessen the likelihood of developing resistance?
Yeah, these are all great questions. Again, I think it is suspected that the majority of patients with advanced GIST, again, these are not situations where there was one tumor removed and is using GIST in what we would call the adjuvant setting, right? When we don't have evidence of disease. This is when the disease presents with large tumor volumes within an individual. The majority of people will develop resistance. Now, we know from some of the early trials with imatinib that it's not everyone, but the majority of people will. And we usually say it's about 18 to 24 months where we begin to see that resistance develop. But there's a lot of variables in that. And I don't want to say that to scare people, but it's really, I think, has to do with a lot of the genetics of a person's tumor, how heterogeneous, that disease is from a genetic standpoint. Also, I think the tumor burden, because the more tumors in an individual, if you believe the model that a lot of these resistant features are existing when the tumors first develop, that there's more opportunities for those resistance to be present in people who have higher tumor burdens. So that also calls into question whether or not removing some of these tumors after a response to Gleevec in the first line setting can really help improve outcomes. And I'm a firm believer that it can, because again, I ascribe more to the theory that these resistant mutations are there. And if you treat someone with Gleevec and you can really lower their tumor burden, the worry is that in some of the tumors that are still there, which may equate to billions of cancer cells, there are these other clones that can develop over time. So if a skilled surgeon can go in there and really remove that disease, I think there's a higher likelihood that a drug like imatinib could work for longer periods of time, right? So although, we use numbers of 18 to 24 months, the hope is that you're in the hands of some really thoughtful clinicians who will do everything they can to put the favor of this treatment in your benefit, right? And surgery is often one of those ways. And I'm a firm believer of lessening, that disease burden when opportunities arise.
Great. This is a specific question to Repretinib. The person wanted to know if back pain is a side effect of that treatment.
Yeah, it's tough because back pain can be a very non-specific complaint, right? And there are a lot of different things that can cause back pain, from just having disc disease to the location of some of the tumors and whether or not there could be fluid in the belly. But all drugs can cause a a back pain, and there are different potential mechanisms from that. There's also a potential disease mechanism where if it causes inflammation in tumors, that can cause a pain. Some of these drugs can cause a myositis or inflammation. Some drugs can cause an arthritic component. And back pain is very hard on a clinical trial to tease out specifically for those relations. Is it drug related directly? Is it drug related based on effective disease? Or, can it be a confounder of the aches and pains that people go through? So generally with a complaint as vague as back pain, the best thing to do is really sit down with your treating clinician so you can tease out exactly, what is that pain? When does it happen? What makes it better? What makes it worse? And then what are the tests that could potentially do to say, is this drug related or not drug related? Because all of this could have implications of how we use a drug, the dose, the schedule, is it prohibitive? And with any of these drugs, especially if they're helping, the goal would be to minimize side effects so that we can keep you on the drug as long as possible.
Great. Is the combination of the PLX 9486 and sunitinib cytotoxic versus cytostatic?
Yeah, so it's a great question, and I don't know if we know. So cytostatic means that we are suppressing the growth of the cells. And oftentimes, you can conceptualize cancer cells as always wanting to grow or cycling. And what cytostatic means is that we're not necessarily killing the cells, but we're shutting them down. And that's something that we know that happens with imatinib, and why resistance can also develop, because these cells aren't necessarily dying and disappearing. That's what we call cytotoxic. We generally think of cytotoxic therapies as chemotherapy that we use in cancers, which actually kills cells. And it's one of the reasons why I'm very interested in the MEK and imatinib story, because there was a lot of signs that was actually killing cells as opposed to just shutting them down. It's a little difficult for me to know, and there may be data out there that I'm just not aware of with the 9486 and sunitinib drug as to whether or not there is some synergy that's allowing for more cell killing. But if you think about both compounds are typical tyrosine kinase inhibitors, so I imagine there is some killing within them, but the majority of those drugs are going to be cytostatic. So it would require, a little extra synergy or maybe some additional targeting within that combination that is allowing for a cytotoxic effect, if that makes sense. Ultimately, it's going to take time and studying some of the samples if we get them from people on clinical trials.
Okay, and then you had just mentioned about that MEK trial. One person wanted to know, is the use of MEK inhibitors an option for us now, or is it still in trials and not FDA approved yet?
It's still in trials and very early trials. And, the hope is that these type of data are the first data to suggest another avenue to treat people with GIST and potentially allow for earlier on treatments, but also it's targeting an aspect of GIST that we never targeted before that we think is really important to the development of these drugs. Development of drugs in this disease. So really coming at GIST in a novel way. Importantly, we feel that the tyrosine kinase inhibitor, like the imatinibs, the sunitinibs, the repretinibs, are really important to be active. And for a lot of people who are listening to this, they have probably been on a few drugs, right? And you want to make sure that that tyrosine kinase inhibitor is working if a MEK inhibitor is combined to it. And that's one of the reasons for starting this development strategy in more of an upfront setting. But it isn't yet ready for prime time because these results are still very early, although intriguing and promising. As you can see, as we really develop drugs from early clinical trials to later clinical trials, so many caveats come into that, and we have to temporize our excitement in combinations like 9486 and sunitinib and imatinib and MEK, that we make sure we develop these correctly so we can fully understand how well they're helping and for which people they're helping, and that's critical.
Excellent. This may tie in a bit. This person thought your presentation was excellent, especially liked how you mentioned the possibility that specific medications themselves may be driving what resistant tumors develop and how we can utilize treatment sequencing to get ahead of that. You also mentioned using circulating tumor DNA testing. This seems like an excellent tool to have in the arsenal, but lots of clinicians seem hesitant to use it. Can you
Yeah.
comment on why this may be and how you utilize it in your practice?
Yeah, right now it's very exciting, but it's still experimental and academic. You know, it I think GIST is one of the diseases where understanding circulating tumor DNA is going to inform all cancer care. It's a disease that's ripe for this technology, but it's taken a long time to set up these technologies in a way to know what we're capturing is potentially relevant for the individual. That's first and foremost. And then, second of all, we need to begin to understand the patterns that we see, because when we get information, we can often become too reactive to that very specific information. You know, just as we sometimes will treat a scan as opposed to a patient, or when resistant mutations first came out, you know, the thought of being an exon 17 mutation, there was this linearity associated with it as that's, you know, the main component causing the harm. So we have to target that. But now what we're realizing is that it's very complex within the human body, and that we have to understand that complexity, and we have to understand what mutations may be causing issues at time and what is the spectrum of those mutations. And then we have to also think about the drugs that we have and how do they best target that. And that becomes critical. And in my opinion, the circulating tumor DNA is going to be an exceedingly important piece of that puzzle. But what I'm waiting for, I think, and much of our community is waiting for, is, you know, data that begins to emerge from some of these larger clinical trials that have already been run. Because if we can get circulating tumor DNA results of the spectrum of mutations that were on the Repretinib study, the Avapritinib study, you know, as they were coming out in the 9486 and Sutent study, it's going to give us an idea of what's really happening, you know, from a cellular level in people, and then how they responded to drugs. But we're very close to applying, you know, these types of therapies in people, and hopefully then being able to individualize appropriate treatment for people, right? So we don't necessarily always fit into an imatinib, sunitinib, regorafenib type of schema, but maybe, you know, after imatinib, regorafenib may be better for people, or Repretinib may be better for people. But we're still a little time off from fully realizing that, but we're getting closer. So have a lot of hope. And in my mind, down the line, which is a much harder study to do, is understanding circulating tumor DNA and its effect in the adjuvant setting. You know, people have been Gleevec for years. Can you stop Gleevec? And are there things to follow in the blood to know if they're at high risk or low risk? But that will take a lot of people and a lot of time to study. But theoretically, it's there, and the technology is just growing so quickly. So we're very excited about it, but we also don't want to overreact, because then we can not necessarily apply treatments in the right way.
Wow, very nice. So the next question is, can you comment on the Daiichi Sankyo drug as a delivery vehicle for more traditional chemo components? I don't know.
Yeah, I specifically left that drug out because it's still very early on in the development. And I have to say, I'm not yet involved in the clinical study, so I haven't had my hands on the drug yet to know how people do and how people are doing. Although I will say some phenomenal colleagues are working on it, so I have the utmost faith that we'll get there. And to me, it also calls into when we feel comfortable, you know, moving away from kit directed therapies like, you know, the Gleevecs, the Repretinibs, and work with adjuncts to that targeting, right? An example is with immunotherapies. I'm a firm believer that we need an active KIT inhibitor to augment immunotherapy versus saying just do immunotherapy alone, right? Because then you're maybe still letting that KIT receptor drive this. It's why with the MEK inhibitor, we want an active KIT inhibitor with it, right? So a lot of the newer compounds, we really have to understand that interplay with the kits of the world, the ETV1s of the world. But there are in cancer these days multiple modalities to better deliver therapies to tumors, and KIT will benefit from that. It's just a matter of understanding the right ones and how to do that, right? That's the, a silver lining of cancer care is things aren't done in isolation. So the studies with the Daiichi compound are going to be really important to better inform not only how to use that, but also how to appropriately develop treatments for people.
Very good. Well, I learned a lot today, and I'm sure the audience did as well. It's, I think, the type of presentation that it's worth keep going back to listen to, because there was a lot of nuggets of information in there. So thank you very much for presenting all this today, and for being such a good friend of the LifeRef group, for doing these presentations with us. We are out of time, so I just want to let everybody know this will be archived and up on our website shortly. You'll be notified about it. But with that, I just want to thank Dr. Tapp and everybody for joining, and have a lovely day.
Yeah, thank you all too. And thank you, Sarah, and the LifeRaf group for all you do. And, it's such a wonderful community. So I'm really excited how we're all going to move, better treatments into the clinic for people.
100%. Looking forward to it.
All right.
All right. Be well, everyone.
Take care. Bye-bye.